Stop sitting around in your comfy chair. Gaze out of your window, look what's there, it's a new world. So go out and find it. Don't feel alone, 'cause there's someone there. Keep on climbing to the top of the stairs. It's a new world. So go out and find it. Step by step with the ones you love. Under the stars, clear skies above. It's a new world. So go out and find it. Keep on doing all the things you do. Hope in your heart will see you through. It's a new world. So go out and find it. I can tell you things that will break your heart. Don't stay in the shadows, making you start. I can tell you things that will break your heart. Don't stay in the shadows, making you start.
Okay, hello everybody. Thank you so much for joining us. I know people are still coming in and that's absolutely fine, but we'll just make a bit of a start because we've got some very important guests to speak to you today. So welcome. You are in fact in the right place. And please do remain warm. If you feel the need to sort of do a little jig to remain warm, absolutely fine. You know, I've got the Glühwein tea arrived through the post just in time for this, which was marvelous. It's non-alcoholic, I should point out. So welcome. I'm going to do an incredibly brief introduction to IDEAL, just so that we all have some basis to work on before handing over to our presenters. So this series of webinars comes out of the IDEAL programme, which is a large cohort study of people with mild to moderate dementia and their carers who are living in the community. So since 2014, we've been trying to understand which things make a difference to feeling like you're living a good quality of life with dementia, whether that's as a person with dementia or as a carer. And we're very, very fortunate to be funded by Alzheimer's Society as a centre of excellence. And the other little plug I'll just briefly do is if you haven't yet visited the Living with Dementia Toolkit, I highly recommend that you have a look at that. There's a wealth of resources on there. It is over to you, Martin and Kate. I'm not sure who's starting, so I shall hand to you both.
I just want to say 2 or 3 things. One is thanks, Kathy, for the introduction. Thanks very much to the Alzheimer's Society for supporting IDEAL. And we all have other links with them and really appreciate what they're doing in this area. And then to say what we're going to present is based in part on IDEAL, but it's what Kate and I think. It's not necessarily what the project thinks, and it's not what the Alzheimer's Society necessarily thinks. It's not a, doesn't sound, makes it sound dodgy. It's not dodgy, but it's just to clarify any conflicts of interest. Right, we're going to talk about costs, economics, lovely stuff. Go to the next slide, please. So what we're going to zip through very quickly, we won't take up too much time. Why economics, then a little explanation about cost effectiveness, because that's what we're focusing on in part. And then 3 areas where we can see economics being used in the dementia space. And then I will hand over to Kate, and she will talk us through some of the findings we've got from the IDEAL study to date. So next slide, please. Dr. Charlwood, thank you. I do feel like Chris Whitty, but there we go. Okay, so why is economics relevant? And the relevance comes from this point here. It's scarcity. We don't have enough of everything or anything. We don't have enough GP appointment slots. We don't have enough hospital beds. We don't have enough money in local authority budgets. All of those things can be problematic, and consequently, whether it's us as individuals or our communities or our country, we have to choose how we're going to use our available resources. And what economics is trying to do is to help decision makers, whoever they are, to make those choices. And it's important to emphasize that when you look to get the best out of your available resources, that doesn't mean going for the lowest cost option for the cheapest option, or not necessarily doing that. Next slide, please. So what we think about was, when we're doing economics research, is this question about what does cost effective mean? That is, what is the way of getting the best value out of our resources? And the way I like to think about it is these two questions. So if the practice question or the policy question is this intervention effective? So does this drug work? Does this therapy work? Is this policy a good thing to do? If the answer to those questions is yes, or probably yes, then the economic question is it worth it? Is it worth spending the money we need in order to deliver that intervention to get those impacts? So the next little click, please. So what we're asking about, what we're interested in, is the best balance between resources used and outcomes achieved. It's nothing more complicated than that. And the next little click, please. And just to say, a cost-effective service is not necessarily the cheapest. It's the one that offers the best value for money. So this is nothing, beyond what the rest of us do, all of us do in our daily lives, is looking for value for money. We don't go for the cheapest necessarily. We look for the best balance between what we spend and what we achieve. Okay, next slide, please. So if we think about the dementia context, there are basically three approaches to responding to dementia. One is to try to prevent it. The second is to find a cure or some way of modifying the disease. And the third is to offer better care and support. And just another little click, please. What decision makers are interested in then, whether looking at prevention, cure or care, is what's effective, what's feasible, what can we actually achieve, what's affordable, and what is cost effective. So just one thing, we're obviously seeing this lots of excitement now around lecanemab as a potential disease modifying treatment, and I'm not qualified enough to comment on the science of that, but I will comment on the economics, which is that if that does get licensed, it's going to have to be affordable. It's going to have to be affordable to the NHS for it to be widely used, and it's going to have big effectiveness indicators if it's going to be considered to be cost effective within our healthcare system. So there's always a challenge in this area, but at least on the disease modification front, we're seeing some very encouraging signs. So that's very good. So I'm going to show you one slide on prevention, and then I'll hand over to Kate after that. So next slide, please. So on the right-hand side of the screen, what's showing there is a little infographic. It is probably a little bit small for you, but on the slides will be available, the recording will be available. What they're showing is the set of risk factors for dementia that the Lancet Commission identified a few years ago. They did a lot of work for their report in 2017, then revisited in 2020. And there are about 12 of those. And together, if you really paid attention to those risk factors, you could probably reduce the number of people living with dementia by about 40% if everything went well. So we can't prevent it completely, but we got some positive findings. So we did some work previously, which then looked at some of these preventive factors. So the first little click, please. So we looked at, the first one there is hearing loss, which is identified by the Lancet Commission as one of the most important risk factors for dementia, various reasons potentially for that. And what we did was say, if we were to do something better in midlife, people who have hearing loss, what would be the benefit in terms of reducing the number of people with dementia and the costs of supporting those people? And we found that if you get people who require a hearing aid to wear it, and that's probably the 70% of people who have hearing aids don't wear them all the time that they should, so it's quite a big issue. If you could do that, then that would be cost effective in its own right, just for preventing dementia. But on top of that, of course, those people would have better quality of life and other things as well. Second little click, please. Which is the second risk factor, which is hypertension, high blood pressure. And again, what we found is if people are given hypertensive, antihypertensive medication, which is very, very cheap now, that again is effective and cost effective just when you think about dementia prevention alone. And of course, antihypertensives have a whole range of other benefits beyond the dementia area. Next little click, please, which is a third of these 12. This is nicotine or smoking, nicotine replacement therapy. Again, doing something about this, we try as a society to reduce levels of smoking, not really because we think it has an impact on dementia, but if we did look at it from the dementia point of view, even just doing what we do now would be cost effective from dementia prevention considerations alone. So these seem to be like no-brainers, if I can use that expression. And then the fourth one, next little click, would be diabetes. And now we find, in fact, although diabetes interventions in midlife, that's GP visits, nutritionist consultation and so on, they would be effective in helping to reduce dementia risk, but they wouldn't be cost effective thinking only about dementia prevention alone. Of course, if you bring in all the benefits of preventing or managing diabetes better, they'll be hugely cost effective. So I just shown you that as an example of some of the work we've been doing and other people are doing, looking at some of the economic case for prevention. So next slide, I'm going to hand over to Kate.
Thanks, Martin. I'm going to go on now to talk a bit about the results of the economic analyses that we published to date involving the IDEAL study. Now, obviously, some of you will be familiar with the IDEAL study, but I will just say it was a cohort study where questionnaires were sent out to people or administered to people with dementia and their carers. These questionnaires included questions about use of health and social services, out-of-pocket payments for equipment and travel to appointments, and unpaid care provided by family and friends. So far, we have looked at, in our analyses, the costs of care for the sample, how these costs change over time, and whether costs are higher for some groups of people than others. Next slide, Kathy, please. So in our analysis of the first round of questionnaires at the baseline, people most frequently used GP and hospital outpatient services, but did not make much use of social care. About 87% had help from friends or relatives, and unpaid carers spent about 36 hours a week in caring activities on average. So off of the data that we had, we calculated that the average cost of health and social care, out-of-pocket payments, and unpaid care for a person living with dementia were £1,336 a month, or if you had a constant level of service use for the whole year, that would work out at about $16,000 a year. As you can see from the pie chart, most of if you can click again, I think, there we go. You'll see that most of the costs were borne by people living with dementia and their family and friends, and only about a quarter of costs fall to the health and social care system. We then looked at the service use and costs after the end of 2 years. So that was 3 rounds of questionnaires. And we found controlling for demographic factors such as age, sex, diagnosis, living arrangement, and socioeconomic status. There hadn't been much change over the 2 years in health and social care costs for the whole sample, but I will talk about patterns of costs for groups of people in the next slide in a minute, because there were differences there. We also found that the proportion of participants receiving home care was low initially at 10%, but by the end of 2 years, it had risen to 20%. And initially, just over half of participants reported that they or their families were paying for all of their home care. And at the next 2 time points, that percentage was 63% and 48% reporting paying all the full costs of their home care. And lastly, we found that unpaid care costs at the end of 2 years were 1.5 times higher than they had been at baseline. Next slide, Kathy, please. So then we did look at patterns of care costs, and I've given a selection of results from our analyses. So in analyzing the baseline data, we looked at which factors influence the chances of getting different types of care and just picking out social care, we found that factors influencing the chances of getting social care were the person's relationship to the carer, whether that was spouse or another type of care, relative, friend care, living alone, and socioeconomic status and income level. For instance, non-spousal carers, other family friend carers, and participants with no care in the study were more likely to get social care than spousal carers. And those who were living alone were nearly twice as likely to use social care as those living with others. And then we looked at the analysis, we analyzed the data over 2 years and looking at the factors which influenced health and social care costs over that time. We found that the initial level of costs varied by different dementia subtypes, by living arrangements, by sex, and by care status. And so, for instance, costs for participants with mixed dementia and dementia with Lewy bodies were higher than those for people with Alzheimer's disease. So I was saying that costs for participants with certain dementias were higher than costs associated with people with Alzheimer's disease. Service costs of participants living alone were 35% higher than those living with others. Service costs of women were 15% lower than those of men. And costs of participants with family or friend carers as opposed to spouse carers, 40% higher than the cost of people with spouse carers. And only a few characteristics influence the rate of change of costs over time. This was age, having a family friend type of caregiver rather than a spouse partner carer, and 2 types of dementia diagnosis. And these are all associated with steeper rises in costs over time. So costs of participants with frontotemporal dementia and with dementia with Lewy bodies changed more than did costs of care for participants with Alzheimer's disease. And so a recommendation from that paper is really that NHS and social care planners and providers shouldn't take a one-size-fits-all approach, and people with less prevalent types of dementia, such as frontotemporal dementia, Parkinson's disease dementia, dementia with Lewy bodies, might need more support than people living with Alzheimer's disease. Last slide, Kathy, please. So this is really just to finish up with some reflections on the value of care for people living with dementia. Some of you may have heard of the dementia tax that is said to be faced by those living with the condition. Means testing for social care leaves many people living with dementia who have assets over $23,250, including the value of their own home, paying for their own care. And while many health conditions such as cancer would receive treatment fully funded by the NHS, dementia really has, up till now, had no effective disease-modifying treatments. In the absence of such treatments, people living with dementia can face catastrophic costs to pay for social care and support. This does vary by country. In Scotland and Northern Ireland, councils fund free personal care for older people living at home. And in Wales, councils' weekly charges for home-based social care are capped. But in England, though, councils must ensure that services are available to prevent, delay, or reduce residents' care needs. There is no cap for catastrophic social care costs. In fact, really, social care funding is not well understood by the public, and attitudes to state funding for long-term care really vary, which is perhaps one of the reasons why, despite many commissions and reviews concluding the funding system in England is not well equipped to meet the growing care needs of the aging population, little reform has taken place. In fact, adult social care funding reforms were legislated for in the CARE Act in 2014, which would impose a cap of £86,000 on the lifetime cost of care that a person would have to pay, at which point the government would pay the rest. The CARE Act also had reforms to extend the means test thresholds. But these reforms have not yet been implemented, and until a few weeks ago, they were expected to finally be implemented next year in October. But the cap has now been delayed for further 2 years following the autumn budget. So as we've discussed, publicly funded agencies can aim to get the best out of available resources, but ultimately it is a political decision to decide on the size of the health and social care budgets and how much the state should pay towards social care. And that's all I have to say. Thank you.
So thank you so much to Martin and Kate there for demystifying something which I think a lot of us can struggle with. And now it's over to George for your perspective on how could we best respond to the cost of dementia.
Hello, everybody. Thank you. I'm not an economist. I have been a chartered accountant in my life, and I have worked for the Red Cross and looked at social return on investment for a while as well. I'm going to start from the premise that we need to value quality of life and not just clinical treatment. At the moment, the approach to dementia, well, historically it has been a clinical approach based on, okay, so you've got a disease we can't cure, some drugs may help, go away and live with it. And, you know, things like don't take risks and all that sort of stuff that spoils people's lives. So what I believe is that to live, I'm not sure I like the phrase live well with dementia, but to live as well as we can with dementia or not without dementia, you need to actually keep engaged. You need to keep socially engaged. You need to keep active. You need to keep doing what gives you pleasure. That creates well-being. That well-being will reduce your use of the NHS, your use of social care. It'll delay your entry into supported care. It'll reduce the number of visits you pay to your GP. I mean, there's evidence out there, not that I can quote it, but I've seen bits and pieces from time to time. Dementia UK did a wonderful piece of evaluation work a few years ago about several of its Admiral Nurse services around the country. It was called the GENES, G-E-N-E-S, I think, project. Anyway, what it showed, they were looking for return on investment. And if just ignoring well-being and quality of life, just in terms of savings directly attributed to those Admiral Nurse services, there was something like, I forget exactly, but something like 1.6 times return on the initial investment. That in itself makes it worthwhile. But if you were to add the social return on investment in terms of quality of life, which can be measured, there are plenty of, I say plenty, there are evaluation measures out there which can be used. You would get a much higher level of return on your pound that you invest. I mean, investing in support, proper support for carers, unpaid carers, I guess I'm saying, would again reduce admissions to hospital, would reduce early or delay the early admission to care homes. Carers break down. They don't tend to get much help until they're broken. And what happens then is the person with dementia gets whipped off into a care home, not of their choosing, but just whatever's available instantly. I mean, I know people who that have happened to, and they're gone within hours of the carer saying, I can't do it anymore. So that's a huge cost compared with the relatively small cost of providing peer support groups, for example. And peer support groups, for us with dementia, and I'm wearing my deep 10-year badge, peer support groups like deep groups, whether they're for people with dementia or for carers, sometimes both, we find that they are, and this is not evaluated, I suspect, but we find that they are the best form of support we can possibly have. The cost of facilitating and running a deep group, a peer group, is minimal compared with the amount that you are going to save in keeping your people with dementia and carers, keeping their well-being and quality of life as good as possible. I regularly meet people with dementia who say, this deep group is the highlight of my week. Or carers say, after that group, you know, Joe is really so much better, so much more calm and smiley for a day or so. You know, carers find the same. If they can just talk to each other, they help each other. Minimal cost. Another thing, and this was touched on by one or other of Martin and Cate, about annual reviews, annual health reviews. There was something about diabetes, I think, in one of the slides. At the moment, there is just guidance. There is the government guidance as to what you should expect after a diagnosis of dementia. And there are all sorts of things in there that are very useful, but they're only guidance. It's not mandated, so most people don't get them. We're all meant to get annual dementia reviews, and these don't have to be just a half-hour slot with a GP. They're best if they are a continual process of reviewing, but with a fixed one-year term to make sure they're done. Those reviews should be helping people with their quality of life and their well-being, as well as any clinical things that need to be dealt with. But most of us don't get them. I'm going to say here in public, again, most GP practices claim their QOF points for doing them. I've done research which showed that something about 1 or 2% of people say they have had a meaningful annual dementia review. That's a hit. It is not expensive to do, especially if you don't use a GP. You use a member of staff who actually understands and has some training in dementia. I went to an annual review last week, and the person doing the review was a mental health nurse who'd never done a dementia review, didn't know anything about dementia. She admitted it. I ended up teaching her for half an hour. That's not an annual review. Okay, so I'm telling you this because the cost would be recovered many times over. We could do with research to prove that. If it isn't, it might already be out there. But Martin and Cate, there you go, bit of research for you. And talking of research, I would suggest that an ideal, I think, does involve this, but we should be looking to do research which looks at this very business of exactly what should be done to help people with their well-being and quality of life. And the research looking at the actual return on investment, the social return on investment. And that research, I believe, should always be done with co-researchers who have dementia and co-researchers who are unpaid carers, because they will tell you what to look at. They will keep you rooted in reality. Another thing that would be, I think, give you a huge economic return is an integrated digital system where people can share information, where all professionals, social and medical, actually can dump the information in one place and access it in one place to help the wraparound care that we all need, that we don't get. I know, digital projects tend to drop a lot of billions of pounds down the drain for one reason or another. We just need something simple. It's not beyond the wit of people. Okay, final comment I would say is, if you enable us, if you, the professional world, generally, if you enable us to go on living well, you will get a huge return on your investment. And I believe that there should be a mandated minimum level. And I don't mean minimum as in minimal, I mean a mandated system everywhere. So we don't have postcode lotteries. Everybody gets supported to live well. And yeah, end of sermon.
I love it. Thank you so much, George. That was fabulous. And I like that you've thrown down the baton, you've given us some rallying cries, a lot to think about. I think you're absolutely right. For everybody on the call, I've just put in the chat the link to George's Dementia Inquirers project that he was a part of, which was to do with those very annual reviews about which he was talking. Absolutely, and this is what Ideal is trying to do, is looking at how can we improve the experience of living with dementia. So it is that very kind of quality of life that you're talking about. So thank you to all three speakers, and it's now over to the audience. If you have any questions that you would like to ask, you're very welcome to ask them, to come off mute and ask them live, or if you'd rather type them into the chat.
I'm living with my husband who was diagnosed at 55. He's now 62, I'm 63. So we were both self-employed. It's a very randomized young onset Alzheimer's he has. So we're under the situation where, we had years of work ahead of us, and suddenly both incomes cut off at the knees. And I'm just sort of now, 5 or 6 years into this project, I'm actually now starting to really feel it financially quite badly. And I'm just saying that if I had to stop work for a big accident or something, I would be supported, would I not, by society with social payments, etc. If I had an accident at work or something like that. But here I am, I'm completely unable to work. My husband's completely dependent on me. And I'm 63 and I loved my job, absolutely desperate to work. I can't afford a carer. He just gets his minimum PIP, 150 quid a week, which goes on 7 hours care. And I have income from a flat, which I let out in order to pay for the place where we live now, which is in the countryside. So my income is more than the threshold for carers awards. And so I am basically getting zero until I'm 67, which is quite, a long way away from now. And I'm thinking, how can this be right? I mean, and I'm thinking it through, and you just think, well, how do they expect us to actually physically survive on this? I'm actually in the process of selling the flat because we've run out of cash, and I have to live and I have to pay for care. And I'm thinking, how do we go ahead? We've got X number of years ahead of us. We don't know how long. And I have to worry about my own mental health. I have to worry about my husband and finances. And I do not want to be a burden in the future. And the thing that would make me a healthy person would be being able to work. It's a huge part of my life. It's really important, and it's terrible to have lost it. And to sit here completely helpless, but feeling able, I just feel like it's a crisis. And all I want is a few hours a day at my job. And, the world will be okay this year or this month or whatever.
The government basically, and whichever government it is, I suspect this would be true, basically prefer to ignore what they can get away with ignoring. And until we actually have enough volume and impact through our voices and our stories, the same will be true. I mean, loads of us on this call, including, of course, yourself, Mary, could go and talk to your MP, about your story. And the MP would be probably quite sympathetic, but nothing would happen. We need to be being activists. as much as possible. We need to get our voices together, because until we do that, I don't think anything much is going to happen. But the other side of it is, if we can actually have some really good social return on investment and economic return evidence, then I would have thought we could then present the argument that invest now here and you will save a hell of a lot more further down the line. And that's, you know, look at the NHS at the moment. We've got enormous waiting lists, et cetera, for all sorts of reasons. Well, it's a lot to do with austerity, though, for the last 12 years. But we've got an aging population all of whom are ending up on waiting lists now. Now, if you invested to save, you would shorten those waiting lists. And the same is true of dementia and all the medical help. I'm rambling here. The medical help that we're going to need. Invest now, save later. I'll shut up.
Kate, Martin, I don't know if you wanted to respond at all. I think, Mary, thank you for sharing, because it's really important that we hear about these realities, because this is absolutely what we're talking about. And as Kate showed in the presentation there, you know, what Ideal really reveals is how much of that burden is being shouldered by unpaid carers. And, you know, I mean, we have at least that data that we can use to try and lobby for change. But I mean, we don't have the answers, I fear. But Martin, sorry, over to you.
I mean, two or three things to say. One is, I mean, there is evidence about carer support interventions of various kinds, including support for family carers of people living with dementia. The START program works really well. I think what Mary is describing, however, is, you know, the complication. I think most of the interventions for carers, most of the attention focused on carers, tends to assume that those carers are not actually wanting to be in the paid workforce. They're, you know, older people looking after a spouse. And so the attention hasn't focused on those people who are trying to combine caring with a career, or, you know, the balance that Mary talked about so eloquently. And I absolutely agree. I think, you know, this is a challenge. And you know, George also pointed to the fact that the evidence is there. The voices have been shouting, but well, the listening has probably been happening, but the action hasn't been taken. That's the problem, I think. And I think over time, I think we're seeing, you know, a growing number of people who are carers wanting to, you know, continue to have a life, whether that's a life as employment, in leisure, and so on. And we need something to take that into account. There is a carer strategy, which I don't know where that's got to in terms of policy planning, but yeah, I think what we're hearing is some very eloquent anecdotes, but really important anecdotes, if you like, personal experiences, which need to be factored into that policy change.
Absolutely. Thank you, Martin. And I think it's another highlighting of where things can get stuck in that policy pipeline, because it's another example with the one that Kate ended her presentation with. So in the chat, we've had another question. Oh, also you're fabulous, George. Leslie is going to use your speech to lobby in her area. So fantastic. So Keith has a question around that part of the problem is always, how do you measure quality of life? It's very difficult to measure from the outside, because the person best placed to measure it, i.e. the person living with dementia, is perhaps seen as a disabled person, and perhaps that judgment is coming more from outside than from the individual themselves. And it makes me think of what you were saying, George, about the deep groups and the amazing support they offer, but how do we sort of capture that in a way that can then be taken forward?
I don't think we should assume, and I'm sure we're not really assuming, that people who have dementia are disabled to the extent that they cannot respond to questions asked. Legally, we have a disability, and that's fine. I'm not going to challenge that, because we need it in order to access rights, even if it's pretty difficult to. But I think there are ways of communicating with people, even in advanced dementia. And there are ways of interpreting behavior if you understand dementia and how unmet needs affect people. There is no reason why we shouldn't be able to carry out quality of life research and evaluations on people with dementia. I just, we're not disabled, full stop, by our dementia until we get very, very far on. We may lose some functions, but we don't lose many for a long time.
That could, I confess, that's probably me mangling the question slightly, and I apologise, Keith. But you're absolutely right. And there's also a study, Aware Care, that I know that Linda Clare did a while ago around exactly that, observing people to understand what makes a difference to them, even if they're beyond language, perhaps. Martin, Cate, would either of you like to respond to that before we go to our final question?
There are many measures, and it depends what you mean by quality of life, which is kind of different from well-being as well. And economic instruments around health-related quality of life are they're measuring health-related quality of life very strongly. And that may not really be the same as what George was talking about or Keith was talking about in terms of what they mean by quality of life to themselves. It might be life satisfaction, might be well-being, or it could be quality of life. And all of those things are actually looked at in other parts of the IDEAL study. There's been lots of work done, and including what people, trying to figure out an instrument, right, to measure what people feel is their quality of life. But that's not what we've been working on, but I know that's part of IDEAL. So just to acknowledge all of that.
I mean, just very quickly following on from that, I think, there's objective quality of life, there's subjective, and I think it's really important that we do give people opportunity to talk subjectively about their experiences. There are health-related quality of life measures which are generic, and I've been involved in developing one which is dementia specific, which is really trying hard to allow people, even with quite severe or moderate to severe progression of their dementia, to be able to respond and participate in that. It's really important we do that. But over and above that, I think it's what we're hearing is we also need to look at this sort of very high level psychological well-being. What is, how you feel today, your life satisfaction, and IDEAL is definitely trying to do that. And I think, these comments that we're hearing today just reinforce the need to do that. So we need a health focus, but we also need to remember that people, health is important in people's lives, but it isn't the only thing that concerns them, and other things need to be measured.
Absolutely, beautifully put. Thank you for that. So just before we end, we've got an excellent question which I'm going to put out, and then we'll see if maybe each of you has maybe one suggestion you'd like to put forward. So Amanda is a second-year adult nursing student, and sort of maybe 1 in 4 patients come into hospital due to another health issue also have dementia. Have you got any suggestions or advice as to what nurses who are caring at the bedside of people living with dementia can do to help?
I think what we've done really well in this country, we still could do better, but we've done very well, which is to try to make sure that everybody working in the health system has an understanding of dementia. Now, we're not got there yet, but we have this much better understanding of dementia than we had 10 years ago. And so the fact that this question is being asked is really important. So that's great. I think it is just making sure that nurses, doctors, OTs, whoever it is that are in contact with people living with dementia have an understanding of the condition, even if they're not treating the dementia when they're coming into that contact, but they have that awareness. So it isn't a very specific suggestion. It's just keep reinforcing that exposure, that training. Yeah,
I would go on to say, find out as much as you can about the person. Not necessarily. Don't regard them as someone with dementia. Regard them as a person. And find out what they used to do. Find out whether they like sugar or milk in their tea. Find out if they like a special mug. Find out if they, have got children, grandchildren, because you will make connections immediately. Just throw a few curved balls at them, or even straight ones for that matter, about my sister's got two grandchildren. And or something, and people will pick it up. Or if you know someone was a bus driver, then you talk about driving or buses or having visited Yorkshire or something. You'll find you connect, and then you can communicate, and then you can take care of that person.
Wonderful practical suggestion there. Love it. The one thing I would say is that Wales have produced a hospital charter, dementia-friendly hospital charter, that they're trying to roll out across all hospitals, which might be an interesting look if that's your particular interest.
So has England, but it hasn't really done much yet. It's been rolled out. Loads of hospitals signed up to it, and they've done very little.
Thank you so much for rejigging what you were going to say there, George. Okay, I can see we've still got questions, but we are going to have to end because of the time. So I'm just going to briefly share my screen to let you know, in case you don't already, that our next session is on the 23rd of January. We'd love to see you there. Where you can meet the Always group. It's going to be a great session. So please do sign up for that on Eventbrite, should you wish to. And it only remains for me to say thank you so much for coming, for supporting. And if we can give, it might necessarily have to be silent, but our thanks to all three presenters for really insightful and interesting presentations.